Good morning, everyone. Cataract surgery, everybody, I think, does it. But the but the but the management, post-operative as well as pre-operative management of these patients is always a subjective matter. And AIS also actually could not draft any guidelines that this is what should be followed. And honestly speaking, I have seen, the post-operative जो पर्चे होते हैं ना, there are people who will say 10 medications, and there are people who will say only one medication. And you see, whenever I get my somebody operated, so I use only one drop only. But I am amazed to see very high volume people also giving 10 kind of medications, everything on the earth, NSAIDs, antibiotics, steroids, cycloplegics, lubricants. So I agree some of them may be required, but I am very straight and blunt in this. So in this session, which is entitled Medical Management of Post-Cataract Surgery, we will, through three, four talks, try to get some consensus that what should be the medical management. And maybe this may be the foundation stone for getting some guidelines. You see, my weakness is always that evolve some guidelines, minimum possible guidelines, which should be followed by everybody. This may help you sometimes in court of law also. And that was the genesis of when we drafted, AIOS guidelines for infection control also. So we have to learn each other, and believe me, this is a dynamic thing. Whatever is sacrosanct today may not be tomorrow also. So with this small intro, we'll begin with none else than Master Kamal Bandhu Kapoor, who will tell us about the role of moxidexafixed combination. Because all surgeries will have some itis component, inflammation also, and some pain. So my friend Kamal Kapoor will tell us about this.
A very, very good morning to everybody. Thank you, Dr. Lalit. I would agree, there is a spectrum of...
I will request Mosita to please join us here.
Could you please put on my presentation? There is a spectrum of post-operative regime which all of us would be following. It can vary from the place you're working at, the competition around, whether you're a corporate or non-corporate. Yes, I agree. There are a lot of factors which do play in, but there are some sacrosanct rules. Sorry. There would be some baseline protocols, I think, which we can have a common agreement on. And one of them is a fixed dose combination of a steroid and an antibiotic. So we know, nearly 2% of patients beyond the age of 50 are suffering from cataract. Cataract is one of the most performed ophthalmic surgeries. And the best part is the patient has to go through it twice at least. And God forbid there's no complication, then maybe more. So maximum cause of blindness, clear corneal incisions, definitely all the literature has shown to us that the increased incidence of infections are there. And what would be the management strategies? There are two strategies. One is you have to avoid your post-operative infections and, of course, inflammation. And eye, as ocular surface, as we all know, is a very sensitive organ. It is more prone to surgery-induced inflammation. And another dictum which follows is longer the surgery, more the inflammation. More the manipulation of tissue, more the inflammation. So these things are quite common. So what I would say is to prevent the infections, you use antibiotics, and to prevent the inflammation post-operative, you use the NSAIDs and a combination of steroids. So what are the peak signs which you may see? You see pigment dispersions, you see iritis, you see uveitis, intraocular pressure rise, pupillary block, posterior capsular opacification, and posterior synechia. And the infections are one of the most feared complications of cataract surgery. And I'm sure all of us as cataract surgeons, our heart skips a beat when you get a call in the middle of the night from a patient, Dr. Saab, pain ho rahi hai and I cannot see. It could be intraocular pressure rise, it could be a Desmond folds, it could be a corneal opacity, but your heart skips a beat because you may be looking at a post-operative infection, and that can be very, very catastrophic. And some of them are no fault of the surgeon. You could have a flora from the patient's eye, skin around the eye, hygiene, whatever. but the blame entirely falls on the surgeon. So how do we stack up? What are the common causes of the bacteria which you see around in the market? In your practice, especially in India, what are the kind of bacteria you see? You see, coagulase negative staph and streps are very, very common, but sometimes you may get a gamut of pseudomonas. And that is scary because pseudomonas, at least in my experience, is one of the most devastating infections which a doctor can have in his post-operative patients. So if you see actually that the most post-operative endophthalmitis is seen in cataract, and logic says yes, because it is the most performed surgery. But there are other reasons why you get more infections in cataract. We'll see that. So the incidence actually varies from 0.03 to 0.2% across the spectrum, across many very developed countries and our country. So why cataract surgery is the most common factor causing endophthalmitis? Of course, because it's the most performed surgery. And second, it's performed in usually the elderly people. Now, elderly people are more prone to surface disorders. Now, let's not take surface disorder lightly. Surface disorder not necessarily just gives you a bad visual outcome and post-operative headache because the patient keeps coming to you saying itching, watering, but surface disorders also cause increased incidence of infections because the protective enzymes in the tear film are actually bad for the bacteria to grow. So you have these patients who are more prone to blepharitis, they are immunocompromised, they are patients with arthritis, usually on steroids sometimes. Hard mature cataracts, again, denotes most of these patients will come to you with hard cataract. You have longer surgical times. You have wound burns. You have fish mouthing of the wound. You have damage to the desmids. So hard cataracts, of course, are prone. Uveitis, MGD. A combination of povidone, at least in my practice we do a practice of cleaning the area with povidone prior to surgery, and after that is done, we take away any tissue paper or handkerchief with the patient. Because a lot of times patients feel a little wet on the eye, he uses a tissue or a hanky to wipe the povidone again. So the person who paints before the operation theater tells the patient, now don't touch your eye. So the povidone painting is done at least 4 to 5 minutes before the patient comes into the theater. After the speculum is put, at least 1 minute of wait soak time of Apadine or no commercial interest here in the phonics, and then a combination of intracameral or post-operative steroids. Now, what is the actual regime ideal? Ideal regime would be to use the antibiotic steroid combination not for more than 7 to 10 days, because after that, if you're just pushing more antibiotics, you're probably just helping resistance come up. Because by now the wound is closed, everything is settled. What you need to take care of is a delayed inflammation. So it's a good idea to shift the patient from antibiotic steroid combination to a low-dose steroid or an NSAID combination. So preoperative prophylaxis, 3 to 4 days prior to the surgery, we put the patient on an NSAID and an antibiotic. During the surgery, choice of the surgeon in my organization, you want to use an intracameral, like I personally don't use an intracameral, but a lot of people in my team do use it, so there is no hard and fast rule. I'm sure there could be a consensus here, but it depends from surgeon to surgeon. Topical broad-spectrum antibiotics, the moment surgery is finished, we put a drop of moxifloxacin in the eye in a combination with steroid, and topical antibiotics steroid combination 7 to 10 days. So there was a consensus, there was a survey conducted, nearly 78% of most of the surgeons prefer using a moxi-dexa combination. This is, again, not a rule, but this is a statistical evaluation which was done. And studies have proven that the dexamethasone has got the most potent anti-inflammatory effect, better than prednisolone also. Though prednisolone may have a better penetration into the vitreous, but dexamethasone actually is more potent anti-inflammatory in these patients. And a combination of moxifloxacin and dexamethasone is a stable combination. You do not usually need a lot of preservatives here. And studies have proven that dexamethasone actually gives you a better post-operative anti-inflammatory control, and has got a longer duration of action. And of course, a combination with NSAID. Now, as Dr. Lalit did mention, use of lubricants. I personally feel when you do an ocular surgery, it's an insult to the tear film and the corneal epithelium. You need to give the poor epithelium some time to regrow. So my combination, ideal combination, would be to put these patients on a sodium hyaluronate combination, because let's face it, sometimes the patients need an anti-glaucoma, and we all know most of the anti-glaucoma agents are bad for your tear film. Secondly, if you're using an NSAID, Nepafinac, Bromfenac, they are epitheliotoxic. And sometimes you need to use an antibiotic aminoglycoside. They are super toxic to epithelium. So you need to give a cover of lubricant. So an efficacy combination of steroid and a antibiotic is a good idea because its compliance is good. You can actually give the patient, use it more of it rather than using combinations, and it's got a better penetration than gadifloxacin. 100 patient studies have proven that with the combination of dexamethasone are pain-free, and most of the results have shown that this is an ideal combination, and as I recommend, 7 to 10 days is an ideal time for using an antibiotic steroid combination. So what I would recommend, what we practice in my practice is a use of an NSAID and an antibiotic 3-day priors. If I have a patient of dry eye, I put these patients on cyclosporin at least 1 week before and a sodium hyaluronate, because these are the patients you could do a perfect surgery. The patient, even after an EDOF or a multifocal, could be 6'6" and 6, but he's not going to be happy with the fluctuating vision because of a bad dry eye pre-existing. So you could do the best surgery possible if you're not taking care of the surface disorder. Infection is not there, inflammation is not there, but guess what? You have an unhappy patient. So I personally recommend using, correcting the surface disorder prior to the surgical procedure. Thank you.
Thank you, Kamal, for elaborating these points. A lot of these points, whatever he has spoken, may be, not evidence-based. Some of them may be evidence-based. So you see, we all have evidence-based guidelines and experience-based guidelines. So I agree there are two aims: to avoid inflammation, avoid infection. Infection, in any case, I think there are a lot of guidelines available. But the use of pre-operative antibiotics is not agreed upon, not a evidence-based. There is hardly any evidence which supports, or level 1 evidence does not exist to the for usage as a routine.
Absolutely.
Only in some one-eyed or maybe eyes at risk, they may be, but otherwise, by and large, no. You rightly said, povidone is one thing which is level 1 evidence.
Absolutely.
And one thing which I would like to highlight, which he has highlighted, the contact time. I have seen a lot of, even at our setup, you put iodine and it's just nurse scrub nurse washes immediately. That is befooling yourself, because it has to have a contact time of minimum of 1 minute in the sac. On the skin, they say 5 minutes, but in this sac, it has to be for at least 1 minute. Mujita, you want to say something?
About cyclosporin preoperatively, you said that if there is dry eye, you would, almost all our patients have dry eye in that age group.
Okay, I would just,
that is one, and then cyclosporin, would it act so fast that if we started 3 days pre-op, would it have its action actually?
Absolutely, a very good point. Let's all agree, cyclosporin does have an immunomodulator and anti-inflammatory effect also on the surface. And in combination with sodium hyaluronate, because these patients, probably some of them are already on, as you said. So what I'm referring to are patients who have a bad documented dry eye. And most of these patients are on your follow-up priorly also. So some of them are on a combination of cyclosporin and even liftigras. I have a lot of patients on liftigras.
The thing is, here we should have minimal possible guidelines rather than the maximum possible guidelines. If you give so many pre-operative,
so I guess let's stick to having a sodium hyaluronate to start
with. If you ask any patient to put any pre-operation to put so many drops, compliance will go down.
Absolutely.
Before you came, I spoke that.
And as is being, since we are talking about guidelines and there are newer treatments available now, some people are recommending, if there is a dry eye and MGD, do one sitting of
ELP.
therapy before the surgery, and then continue with 2 more or 3 more sittings later. Would you recommend that?
Okay, I think this is a very good point. If you do an ELP, I would recommend at least 15 days of time duration and at least 2 sessions of lid massage to express the bad sebum out, because sometimes just after ELP, you may have sudden gush of bad sebum coming out, which is loaded with inflammatory markers.
Yes,
I have attended Dr. Rohit Shetty's amazing lectures, and these pent-up sebum gland secretions have inflammatory component in them.
So that's a very good point, because nowadays some people are doing, this practice has been started, that do a therapy, pulse therapy, and then 3 days later do a cataract cataract surgery. I think this is not to be recommended. If a therapy has to be done, it should be how
2
many
weeks.
days after
2
surgery?
weeks.
At least
At
2
least 2
weeks
weeks.
after the surgery and cataract surgery, and the patient can be primed about this, that you need this also. You already have a pre-existing dry eye, so this treatment may be needed for you 2 to 3 weeks later.
This is a very nice point. This is a very nice point because cataract surgery is not a emergency kind of surgery. You could easily wait for this time. So
but
meanwhile, we'll request
nobody
Madhu
like-
to get ready because cover the questions we can take. We need to finish in time. Thanks, Kamal.
Prior
Thank
to
you.
surgery, he said
weeks prior to
at
surgery.
least 2 weeks, because you don't want it to do it through 2 to 3 days before and have all the
again, I think
sebum load outside.
These are not as a routine.
These are not routine cases. These are bad dry eye patients.
MGD or mebomyelitis, or if there is an active this thing.
One
Otherwise-
small point is if your patient is suffering from an amoebomitis, touch them with a 6-foot pole, at least till you've taken care of the amoebomitis, because sometimes this can be very, very frustrating. So I give a combination of oral doxycycline with azithromycin drops. These are confirmed MGD cases where you
See,
need to
I
operate.
will talk about, Madhu, you can load. See, any kind of drop in myomitis don't work much because you see, remember there are 15-20 glands like this. So how will drop go inside the gland and do it? Mechanically not possible. So what I advocate is, yahan se pakad ke have an ointment, you have to do lid margin scrubs. Then only some antibiotic will go. No drops will go inside. Ointment.
Azithromycin.
You said drops.
Azithromycin.
Ointment is good. Ointment is perfect. But drops, though, you see how much is retention, how much is going to NLD, how much is coming out. So, wo nahi hai. It's the ointment which you have to scrub amongst the gland opening. Then only it will potentially go. And you can, couple it with some kind of fermentation so that it becomes thinner. So, let's have Madhu, who is a prolific anterior segment surgeon. I have visited his place, does an excellent job in Visakhapatnam. And he will tell us about this fashion of fashion. This is a fashion. You see, everybody in this country has NSA drops and lubricant drops because this helps pharma companies, everything. Because everybody has Nipafinac, everybody has Bromfinac or lubricants. So he will tell us where we should use a Nipafinac in these patients.
Yeah. Very good morning to all of you. Firstly, I thank Lalit sir for making me part of this presentation and also JB Pharma. And I acknowledge that the slides provided by the JB Pharma medical team. So I'll just try to share the studies that they have shown why we should use NSAID, especially Nipafinac post-op. And in the ending, I'll also be sharing what the practices that we follow in our place. If you see, overall, nearly 15% of the cataract surgery prevalence that we see in today's scenario, and that keeps increasing year by year. So what inflammation can cause is postoperative pain and photophobia. If untreated, can lead to several complications. So management of post-cataract surgical complication, if you see corticosteroids act at the level of blocking the arachnoidic acid release by inhibiting the phospholipidase, whereas NSAIDs inhibit prostaglandin release by blocking the CO enzyme that convert the arachnoid acid to prostaglandins. So these are two levels in which steroids and NSAIDs act to control inflammation. So corticosteroids, as already Kamal sir has pointed out, is a gold standard to treat ocular inflammation. However, they come with their own set of complications. So it's not that we are going to vote for either one of them, but how do we combine them and use it judicially for better outcomes? So how do we reduce the use of prolonged steroids is NSAIDs can be a safe alternative to corticosteroids, not immediate post-op, but maybe as we progress in the post-operative period, as you taper the steroids, there can be a role of NSAIDs. They're widely used to manage inflammation, CME, and post-op pain. They provide surgical outcomes in routine and complex cases also. So for pain and inflammation management post-cataract surgery, the indication is Nipafinac. It penetrates the cornea and then forms into the Amphenac thing, that is the main molecule that acts in the corneal level. So why Nipafinac? Nipafinac was among the first prodrug that was produced, and it is not like a free acid like any other topical NSAID. Other ophthalmic NSAIDs, due to their water solubility, have limited corneal epithelial penetration when compared to Nipafinac. So Nipafinac, 0.1% for prevention of ocular inflammation associated with cataract surgery. So here is a study And there they have seen 487 patients where you have a placebo and nepafenac. And if you see at the end of 14 days, definitely patients were more pain-free when compared to the placebo that you can see in the second week visit. Next is perioperative administration of nepafenac. This I'm not sure, I don't use this perioperatively, but there are also some studies that 73 cases where they have felt that it has a better reducing inflammation in the post-operative period. Again, there's one more study doing the same thing. So when you compare the visual acuity score and also the thing, 1% has a better patient comfort. So next, coming to nepafenac steroid combination, whether you want to combine it with dexamethasone or prednisolone. So if you see NSAID combination along with the dexamethasone gives you a lower incidence of CME, and they're more favorable flare values when compared to steroid alone. So again, here you have 160 patients where the total macular volume or proportion of the patients of macular swelling is less in the combination group when compared to the single treatment with dexamethasone alone. So this is the dexamethasone combination. Next, you have the prednisolone combination also, where they have seen in 140 patients. And here again, if you can see by group 2, they have a marginal better post-operative iris control when compared to the single use of thing. So the key takeaway is nepafenac and AIOS drug is readily absorbed across the cornea at higher pH levels also. It contains BAC, so BAC is not a bad thing. BAC itself is actually an anti-fungal, and in short-term usage, it doesn't cause much harm to the ocular surface. Nepafenac 1% effectively prevents post-cataract surgery inflammation, pain, and higher cure rate with patients being more pain-free. Preoperative nepafenac significantly reduces inflammation in early post-operative period. And a combination of nepafenac with dexamethasone reduces subclinical macular swelling inflammation along with subjective complaints. And the addition of 1.1% to corticosteroid significantly reduces inflammation when compared to prednisolone alone after phacoemulsification. So in our practice, what we do is we usually start off with an antibiotic steroid combination. For the first week, we don't give any nepafenac. As we start reducing the frequency of steroids, that is when we introduce the nepafenac and give it for a period of 3 to 4 weeks, because the steroid effect starts coming down. And routinely, we give it in diabetic patients, but in other patients, it's up to you to take a call whether you want to use nepafenac routinely or not. So that is my practical take on nepafenac. Thank you. Sir, 3 times till the bottle is over.
The bottle,
Yes,
bottle का मतलब नहीं है, bottle तो we will not talk about bottles here, but no, that is post. Yeah, no. Jokes apart, you see, post-operatively, I think most of us agree. जल्दी करके तो चले जाओ.
Again, for compliance sake, sir, first 1 week I give only.
Post-operatively, we agree that
Yeah.
in the initial week or 10 days, which Kamal also said that 7-10 days, it makes sense for compliance issues that anti-steroid combination.
Yeah.
After that, there is no role of antibiotics at all.
Correct.
You should shift to either steroid or
Yeah,
add
and
nepafenac.
steroid also now we have
Yeah.
better steroids like 1%
So I'm
clotipred
actually,
that
Madhu,
we
more
can.
concerned about pre-operatively.
Pre-op?
See, pre-operatively use of nepafenac, which I was looking
Maybe
for.
like uveitic eyes and all, they may have a role,
Yeah.
sir. Otherwise,
So,
pre-operatively, I
correct.
don't.
So we should distinguish. One is a uncompleted surgery.
Correct.
Other is a completed surgery. In uncompleted surgery, what should we be doing? Because most of the patients, what all of us operate, 90-95% will go routinely.
Yes.
But it is those select 3
Select
to 4%
cases
patients where you will be required. So what I have in my this thing is a fellow eye who has developed a CME in the previously.
Yes.
Then diabetic patients, they're more
Diabetic
prone.
anyway.
Uveitis patients are more prone.
Yes.
So these patients, you should be slightly more careful.
Okay.
So this is one
even
message.
pre-op, sir, you are suggesting pre-op?
Pre-op, yeah. So these patients, you should be slightly more careful.
Yes.
And you showed that cascade pathway, where
Yes.
steroids act on upper
Yeah.
end, then COX inhibitors come low
Yes.
down. So why the lower preference rather than the higher wala drug, steroids?
Yeah, steroid.
I know there are people in Germany and people in other, 1 or 2 more countries where we had webinars. They do not use post-op steroids at all in an uncompleted situation. So what the gentleman dialogue said, one drug once a day, like Nepa once a day is available,
Yes.
Brome also once
Yes.
a day is available. OD once a day, good enough. Nothing else is required. He does not give steroids at all.
Subconjunctival भी नहीं.
Nothing. No, subconscious तो वैसे ही खत्म हो गया. Subconscious तो we also don't give.
No, sir. If they are not giving post-op, probably they are
Subconscious
giving
actually,
something.
honestly speaking, in a cataract surgery is dead actually from my this thing, because I do not see anybody giving subconscious at all. You see, we as retina surgeons we still give, but as a cataract surgeon I don't think so.
No, not in regular cases, sir. In those cases, they are not using post-op topical steroids. Whether they are giving subconjunctival.
Injection.
Huh. Yeah.
Yes. Huh? नहीं, I think say overkill, unnecessary. That is for your satisfaction, for benefit of patient तो नहीं है वो.
Where I did my post-graduation in Dr. Narayan Model in Jorhat, we do not use steroid for any post-op. Only Nepafenac
Nepaf.
and 14 days bivamelagon.
Okay. All cases.
That's what I attended one webinar where I think this point was raised, and I was amazed that they do not use steroid at all. They just give bromfenac or nepafenac or lubricant something. That's all.
Lubricant, okay.
So I think we will
Yes.
go on to the third presentation also.
Thank you, sir.
Because that is DED management of post-cataract. But one thing is there, you see, till the time wound heals up, I have my own friends, relatives operated. We are in such age group that our colleagues also are getting operated. So after this antibiotic steroid, they do complain of some irritation, most of them some irritation or some foramen sensation, and they respond very good to nepafenac. So nepafenac should be continued, to my thinking, at least 4 to 6 weeks, rather than 10 days or so. Yes, sir, you were saying something. I personally, you see, my wife got operated, we used for 6 weeks. I'm telling you honestly. Because she will say, सब कुछ अच्छा है, दिख रहा है, लेकिन वो डालते हैं तो nepafenac ठीक रहता है. My class fellow recently got operated, he's an anesthetist, head of department in Rajiv Gandhi. He said, Lalit, ये nepafenac से addiction हो गया. So in the sense कि he said, there's some foramen sensation and something pricking. He responded 6-5 vision day 1 से, but he now we have stopped only 1 week back.
What about the role of low-dose steroids? Would we suddenly go in for a stop, or we will go in for a tapering or a low-dose steroid?
No, I agree. You see, like Kamal was saying, initially full-strength steroid, then low dose, then taper and finish it off, and then make the
And
patient.
when you are with low dose, at that time only start nepafenac also.
Yeah. Fluormethalone, normally we prescribe fluormethalone kind of drops. There are various things available, but this thing is this only, because it gives good result. And I don't change for the heck of it till the time patient is happy, I am happy.
And we could also, full-strength steroid, after 10 days, we could just taper it off
Taper it off.
over the next
In an uncomplicated
next 10
situation,
days,
yes, I agree with Mohita.
rather than stop.
Yes, Mohak,
Yes. First of all, I'd like to thank everybody for this great conference. Kudos to everybody, and thanks to JB Pharma for allowing me to give this talk. So my topic is, the situation which we face very, very, very commonly in our routine practice, that is the dry eye post-cataract surgery. So by the definition of the DUCE, what is a dry eye? First, we need to understand that. So basically, it's a multifactorial disease of the ocular surface, which is characterized by the loss of the homeostasis of the tear film, which leads to the variety of the ocular symptoms, which I'll be talking about, in which this is the whole cycle, vicious cycle. There is a tear film instability, which leads to the hyperosmolarity, which leads to the ocular surface inflammation, leading to the cell death, and there are other so many neurosensory abnormalities. And if we talk about the prevalence of the dry eye, nowadays, every second patient, not one patient, every second patient in my OPD is complaining of the dry eye symptoms. And if we talk about the global, it ranges from the 5 to the 33%, but in a country like India, it is almost 54%. So my talk is, what happens post-cataract surgery? So we are firstly mostly operating the old patients. They are already, ocular surface is compromised. In case of the female, they have reached the post-menopausal age. There is hormonal imbalance. They are on so many drugs which are also not helping. So what I have found is almost 87% of the patients, they complain of the dry eye symptoms in the first post-operative week. 35 patients, even at the end of 3 months, and almost 10% they go into the chronic stage. So what are the symptoms which our patients usually, complain of? That's the blurring, there is burning, there is dryness, gritty sensation, there is a stringy discharge, there are the crusty lid margins, foreign body sensation, and also the other factors like, environmental factors like we are already working into the AC. Nowadays, the digital use, we don't keep our eyes off the mobiles and the computers. These all cause to the vicious cycle. So it is important that we should diagnose which type of the dry eye our patients are suffering, and this is just the broad guideline I'll be presenting. So most important thing is to diagnose them preoperatively and treat them aggressively. So what you do, it's a very routine thing, even if you don't have the fancy machines, just do the basic Swarmas test, T-bud test, just have the examination of the eyelid, how are the margins, how are the glands, do the staining with the fluorescein or the Lissaman green, and you just have this OSDI question, that's just a simple 12 answer. There are 12 questions being there, and you scale from 0 to 100. You just have to ask the patient. It's very simple. So based on that, you just divide whether the patient is suffering for the aqueous deficiency dry eye or the evaporative, it's a mixed one or the toxic one, neurotopic one. So this is just a broad guideline. In case of the aqueous, what we need to give is the preservative-free eye drops. In many of the times, we are giving the gel on the ointment form, and also the essential fatty acids like omega-3 fatty acids play a huge role. In case of the evaporative, like the Lalit shall say, the ointment plays a huge role. Oral tetracyclines, there are liposomal sprays and oil, they play a huge role. So let us first understand this mechanism. Okay, how does this dry eye happen? As I told you, there is a TL film instability, which leads to the hyperosmolarity, leads to the cell death, apoptosis, there is a nerve stimulation, it causes inflammation, MMP9 and another, they gets released, they cause the damage, and again cause the TL film instability. So this is a vicious cycle. And all these factors, like there is a pre-existing blepharitis, patients undergoing cataract or LASIK, there are environmental factors like I told, they all are responsible. So now we need something, to arrest these various points where these dry eyes are the causing. So to enhance the lubrication and prolong the retention time on the surface, variety of the viscoenhancing agents are being circulated. The main fundamental is that whenever there is a disruption of the tear film, there is damage to the epithelial cells. So while these epithelial cells are being recovered, there is a still chance that our ocular surface can re-injured more. So we need something which works at the ocular surface and it arrests the core mechanism. So that is where the artificial tear drops come into the picture. So before going into the detail, let us just see how they have evolved. So if you see evolution, the first generation came, they are based on the saline-based isotonic or the hypotonic solution with the BAK like preservatives, which personally I don't recommend. Second, there are improvements like the natural and the synthetic polymers like a methyl cellulose, and the synthetic ones like the polyvinyl alcohol, providine iodine, HP-GOR. And nowadays, the most recent kid in the block is the ones which incorporate the hyaluronic acid and the lipid, and I would say the trehalose as well. So now we have all the options. Polyvinyl alcohol, we have HPMC, we have CMC, we have the PEG-PG, HP-GOR, we have HA, we have the trehalose. So, you get confused now, which one to use when. Even today, still, I'm not able to find out the correct one, which one to use well. But whatever the studies have shown us is that sodium hyaluronidase along with the trehalose, because sodium hyaluronidase has a more retention property because it binds well to the ocular surface, and it also has a wound healing properties. So the main goal, like I said, is to, this is difficult to choose which one is going to work on the which patient because all the patients behave differently. But the main aim or the principal aim of all this artificial teardrop has to be to treat the patient's symptoms so they become comfortable. We have to prevent the system escalation as well. And most importantly, why? Personally, I prefer is to dilute or remove any causative agents which are causing the inflammation because inflammation plays a huge role. So keeping in this mind all these factors and the mechanism of action, composition, viscosity, osmolarity, we have to go ahead and choose. This is a very beautiful chart which will show how you manage. So you have this dry eye disease. Now you have done all these tests. You see that you have the aqueous deficiency. So there are the demolidants like the cellulose derivatives, gelatin, lipid, polymers, and along with the electrolyte, they play a huge role like sodium chloride, calcium chloride, magnesium chloride. If we have evaporative dry eyes and oral tetracyclines, there are liposomal sprays, oil, cationic emulsions play a huge role. There is an altered tear osmolarity. There are a lot of osmoprotector agents like L-carnitine, erythritol, taurine, most importantly trehalose. And those who cause the apoptosis and prevent it is the cytoprotective agent like trehalose plays a huge role along with the antioxidants and high molecular weight HA, like we have this now, this is the Rizovati is a combination, anti-inflammatory agents like the steroids come also into the picture, cyclosporine, and high molecular weight CS and trehalose. So this is the vicious cycle. So, it has to be a step-ladder approach. You cannot pinpoint this is a drop I'm going to use. And nowadays, even the company people are becoming smarter. They are incorporating various ingredients into the one formulation. And this is, again, the beautiful chart. This is the basically tear film, lipid layer, aqueous layer. This is what I have talked about, which agents works at the which level. And you can see there is not a single agent which works on only one. So you have to use the combination of this polytherapy. And you have to make sure that you are using a drop which covers most of those ingredients. So why HA? Because HA is, is been predominantly found into the synovial tissues in eye, in vitreous, as well as the some amount is there in the aqueous humor and the connective tissue angle of the drainage angle. So why HA? Because, it is already synthesized by the corneal epithelial cells. It has a good wound healing properties. It binds with the water well, which I'll be discussing in the next slide. So they are basically made of the negative charge polysaccharide compounds. As I told you, they play a key role in the cell signaling, the cell adhesions, the wound repair. So these are the most common functions. The most important ones for the eye are that they increase the tear fluid stability, they increase the T-bud time, they increase the corneal wettability by having the more retention time, they decrease the evaporation rate, decrease the adhesion, decrease the staining, and by thus relieving all those symptoms. So the three most important role, it binds effectively with the water, so it resists the hydration. Next is promotes epithelial wound healing. And third, because of the more viscoelasticity, retention time is quite good. Now let's talk about each one separately. Why they have the more water holding capacity? Because they have the large molecules of the negatively charged ion on them. So what it does, it basically can hold 1 gram, can hold almost 6 liters of the water. That is quite huge. So what happens? Because of that, evaporation of the water from the HA is quite low, so the effects are prolonged. So this is the main benefit. Second one, as I told you, how does it help in the wound healing or wound repair? So this is the fibronectin. It's an extracellular matrix protein which stimulates the epithelial cell migration. So whenever this complex is formed, it helps in the wound closure and the faster wound healing. And third and foremost is the viscoelastic properties. So what is tear stress? It is the force between the tears and the ocular surface. So we have these viscous properties of the liquid and the elastic properties of the solid, in which combined we get this viscoelasticity. So what happens whenever we blink? These molecules of the HA, they are aligned with each other. So what happens? They become elastic and the non-viscous. So they are spreading uniformly. Just see like this. That is the most important thing. And what happens between the blink? It forms a tangled meshwork. So the solution becomes less elastic and more viscous. So the retention time is quite good. So you get the advantage of both the things.
What we need to wind up?
Yeah. I would like to stress trehalose. Trehalose, we all know it's a sugar. And how does it help? It helps in retaining the, surviving the organism in absence of the water. It basically osmoprotective agents, prevents the denaturation of the protein and osmoprotector agent. And the three factors which I said is that it rehydrates the tear film, protects against the further irritation, and supports the homeostasis of the tear film. And this is just the summary of how does it work. And nowadays in my routine practice, I'm using this combination of the HA along with the trehalose, that is the Dizovati, that is my first choice of the drug. And what I have found is that they are quite effective in not only reducing the patient's symptoms, but against the tear film stability. And when we compared it with the other patients, when we give only the simple lubricant, they work quite good, even with the existing mild and moderate dry eyes. Thank you very much.
Thank you, Mohak. I think we come to the end of this session. But just to summarize in 3 lines, because 3 speakers, 3 lines. One is that, it's better to use antibody-steroid combination, but only for a week or so, then shift to steroids and low potency. Then Nepafinac drops to be started once, this steroids effect is waning off. And lubricant, I think I agree that HA is one of the principal agents. So normally, I was telling in the beginning only, when your parent or your father gets operated, I normally give only Vigadex eye drops. I do not give anything else, except once they start complaining of any pain or this thing, we add lubricant. So do not use that 1 page full of drops. So many drops we find, antibiotic, steroid, oral antibiotics, so many things are being prescribed. Nothing is required. Nothing is required, I'm telling you honestly, that I am depending only on 1 drop Vigadex, so that's good enough. And then Nepafinac we add, and then lubricant what he has suggested. So I think this is the takeaway.
Just to add
I'm not forcing that you do this, but be scientific in your approach rather than Yes.
Just to add on to what Sir said, sodium hyaluronate has always been a gold standard for treatment now, and but with newer drugs coming, trehalose seems to be
Yeah.
something which can be added as a combination or separate, preferably as a combination, because it's an osmoprotectant also, and because of its autophagy, somewhere it works as an immunomodulator and anti-inflammatory also.
I think Mohak said in the last line that combination of HA plus Telos. So thanks a lot. Thanks everybody for being with us. And we just wind up, and with thanks to all the speakers here. Thank you. All the speakers can come. We have a group photograph here.
Research